should work.
There's more water there if you need it. Thank you.
Sangai la, Hadala Isis, Atlanth is di Goodnight Lagan, Helen Sanderson, di Non Uijan, Robert Kogo, di Chin Uijan, Francis Sanderson, di Au Uijan, Robert Sanderson, di Hut Uijan, Jana Towne, Hinu di Keung, di Uhatagan and Klinkit, Gatsakas Gustik Walagan, Heidelberg Stuith Egan. Good day. Hello, all you good people. I'm happy to be here with you. Helen Sanderson was my grandmother. Robert Kogo was my grandfather. Frances Sanderson was my mother, and Robert Sanderson was my father. My name is Jana Towne, and I am Haida and Tlingit. My moiety is Eagle, and I'm from, as you heard, Heidelberg, Alaska. And I'm grateful and honored to be welcomed with you all here today on the lands of the Dena'ina people, and to get to talk about social determinants or social drivers of health. We're going to talk about that in a little bit. You'll hear me use those terms interchangeably a little bit. But before that, I kind of want to get a little bit of a feel for who's in the room. I think from talking to conference organizers, I have a little bit of an idea. So how many diabetes educators are in the room? Okay, quite a few, all right? And some of you may have to raise your hands twice. How about nurses? You heard I'm a nurse, okay? Quite a few nurses. I know there's at least one pharmacist in the room. There's a couple. Okay, see you. How about community health aides? 1, 2? That's just 2. My grandma was a community health aide in Heidelberg for all my years. You were my health care for most of my childhood. How about exercise trainers? Got a few of those in the room. Okay, and then did I ask about physicians? I didn't. I know there's at least one because he's at my table. And 2. Okay, who did I miss? Dietitians. Oh my goodness. That's terrible. Okay, wait a minute. You got to raise your hands again now. 1, 2. Okay, gotcha. Anybody else I missed? What was that? Oh, seriously, we have some informaticists in the room? That's awesome. That is amazing, actually, because you make a lot of the other things that we need to work to give good care possible. So I'm really excited you're here. Okay, all righty. So let's talk about social drivers of health and diabetes in American Indians and Alaska Native communities. And hopefully this gets us started off in a good way to think about all that's on your agenda for the next several days. There's a pretty robust agenda. As I was looking at it, I'm kind of excited about a couple of the sessions that I saw. And I'm going to see if I can work this. Aha. Okay. So I like to begin with this mural. And what it says on it is, Aji Wadlawan U Good Health Kiwagan. Sorry. My mouth does not speak Haida very well when it's dry. And this mural is one of a series of murals that actually depicts the work of amazing women in science. This particular mural actually represents the work of a childhood friend of mine who actually happens to be here, and we will be doing a session today later in this same room after lunch. And she's a professor at now University of Alaska Southeast, but grew up with me in that small little village of Heidelberg. Anybody here from Southeast? Anybody here? Got a couple? Okay. Anybody from Prince of Wales? Oh, I see you. I figured when you told us who you were. But we grew up together in this village, and it represents 3 Haida women and their interrelationship with earth, wind, and water, and many other things. You see our moieties in there, you see her clan. But more importantly, it represents our understanding of the world, and that is that everything depends on everything else. Another way to say that might be that everything is connected. And it's why we're here talking about social drivers of health, or SDOH, today. It's why they matter. So I always begin with some kind of foundational slides to make sure that we're all on the same page when I'm talking about SDOH. And social determinants of health, you see here the Healthy People 2030 definition is the conditions in the environment where people live, learn, work, play, worship, and age, and that affect a wide range of health, functioning, and quality life outcomes and risks. Big words. And a long definition for describing what we think drives health in the country. And you see in the graphic that's to the right, the domains of the social drivers of health. And just in case you're in the back of the room and you can't see them, you see that you have access to health care and quality of health care, neighborhood and the as-built environment, social and community context, economic stability, and education access and quality. And I mentioned already the interchangeability of determinants and drivers. I'll share with you that lexicon is shifting in healthcare and in the country. Social determinants of health was kind of where a lot of this language started. But even before the shift at the national level with HHS, we've been using the term drivers of health in the Indian Health Service. And the main reason is that when you talk about determinants, they sound permanent, they sound immutable, they sound decided, like they've set the future in motion and that's all there is. But social drivers of health are neither positive nor negative, and they are what impact health. But we know that it's possible to positively impact health as well. And in our Native communities, many of the things that we'll talk in a bit actually can be useful in driving towards health. So you'll hear me use drivers to communicate that opportunity to impact health in a positive way, as well as acknowledging the things that may negatively impact health. Y'all are here to improve health, right? I know it's early in the morning, but you all are quiet. Okay, a little bit more on terminology. Determinants, drivers, other descriptors. You hear social drivers of health, social determinants of health, social risk, health-related social needs. They're often used interchangeably to describe social drivers of health, but there are some differences that I think it's important for us to understand. So one, social determinants or drivers of health, you heard me describe already as the community level factors that affect health. They're often referred to in the negative, and they're thought of as those causative factors for health disparity. So causative for health disparity, but also for health. And then over on the lower left, you see social risk factors. And social risk factors are risk factors that are created when adverse social conditions exist in a community, and they create the potential or risk for negative impacts. So social risks may be present in a community, but it isn't until somebody experiences negative impacts on their health that they actually have health-related social needs. And HRSNs are often used interchangeably with SDOH for our informaticists in the room. Some of that got hardwired into the US CDI despite our efforts to change that. And so it drives a little bit of the language in the lexicon. But looking at the health-related social needs again, it's when those needs and risks in the community are realized and not mitigated that an individual begins to experience that impact on their health. And that includes things like unstable housing or lack of access to nutritious foods, and then they experience health-related social needs. So just to put a fine point on it, social determinants or social drivers of health are the conditions in the community and the environment that one lives in that do or do not support health. Social risk factors are also those conditions in the community, but they create a potential for people to experience adverse health impacts. And then when one actually experiences the adverse impacts on their health, they have health-related social needs. And what this looks like in communities is that SDOH might be present in a community, an issue like food system challenges might be present in a community. And so whether or not you have enough grocery stores. I come from a tiny village that for most of my childhood, things came in on a barge. And so for a couple of weeks, you had a lot of really great fresh fruit and vegetables, and then the rest of the month, you had everything that was shelf-stable. And that's probably not unlike a lot of people in this room. So when those issues are present in the community, that creates social risk, right? That creates a risk that somebody might not have access to healthy, nutritious foods to live and grow and be well. But if you're somebody like me, my parents traveled a fair amount when I was young because they were on things like the Tlingit and Haida board and the Alaska board. So they could bring fresh fruits home on the seaplane, and they could bring yogurt. So while that risk factor might have been present in the community, I didn't experience that risk factor. I had access to healthy foods. So I think it's a worthwhile distinction to understand that just because social risks are present in a community, you don't know if the individual in front of you is actually experiencing a health-related social need unless you engage in a conversation with them about it. And whether or not they actually perceive that to be a need is a whole nother thing. I think you could argue that because we don't have grocery stores, some people don't have access to healthy foods. But I spent all of my summers as a child gathering and putting up berries and food and fish, and those don't come from a grocery store. So a Western way of measuring that might not always catch those kinds of nuances. Okay, so now that we've talked about what they are, why do they matter? So this graphic that you see on the left of the little guy with the percentages on him represents information that's come from the county health rankings model from the University of Wisconsin. And we now have over 15 years of annual data from all of the counties in the United States about health risks that are present in the community. And what's important about this bit of information is in that 15 years of data, we've learned that the health differences in the differences in health outcomes, that people experience are actually related to the social drivers of health. So if you look at the top of this this image, you can see up at the top the socioeconomic factors of education, job status, family support, and income. And what we learned from this data is that almost half of the differences in outcomes that people experience result from those social drivers of health. And you can see down at the bottom, healthcare, we're this 20%, and we put a lot of effort into trying to work in our communities and to get people healthy and work with individuals and change the course of the health trajectory in our communities. But if we don't understand that at least half of that is happening with what's available in the community and what supports there are for health, we're fighting an uphill battle. I would actually posit to you, though, that it's more than this 40 to 50%. I actually left out physical environment. Sorry about that. Because if you look at that yellow band down at the bottom, middle, that includes the health behaviors, so things like tobacco use, diet and exercise, alcohol use, sexual activity. Those health behaviors are also often impacted by what's available in a community. Right? If you don't have a safe place to get out and exercise, you're not getting the physical activity perhaps that you need. If the environment around you is unsafe, it may affect stress levels that affect how you cope and the kinds of things that you do to exist in the world. So I would actually posit that it's closer to 80% when you consider the factors in the community and then how that influences how we interact around health behaviors. Moving to the graphic on the right, I'd like to point out that those social factors that we've talked about, so things like education and job status, family support, income, those are all upstream factors. And when we're talking about individual interventions around health-related social needs, we're here in this downstream space. And it's where healthcare spends the vast majority of its time, is in that interactive one-to-one level, trying to change the trajectory of an individual who's experiencing health issues. And we're starting to move into this midstream range a little bit more. Some of you may be familiar with requirements to screen for SDOH, but what did you learn if we're screening for food insecurity, transportation, personal safety, interpersonal violence? What did you learn that those are actually if they're not SDOH? Somebody say it. Those are HRSNs. They're health-related social needs that we're actually screening for. And so as systems, we're starting to begin to screen for those things and try to understand what the individuals that are coming into our exam rooms are dealing with and address those. But if we can't address what's available to them in the community, we're really still working in that midstream range. And so until we start working on changing the conditions that cause the needs that the individuals that are coming into you are experiencing, we're going to be hard-pressed to actually get those changes to occur. So I'm going to encourage you today as we sit here and we go through the rest of this talk and the rest of today, start thinking about how do we push up into this upstream area? How do we start affecting the cause of the causes of the things that bring our people into clinics with health challenges? And then before I leave this slide, I want to call out one last point about the county health rankings model and data. And that is that data acknowledges that those are modifiable conditions that are leading to health outcomes, which means they can be changed. And I think for years, healthcare has really thought about social drivers of health as just kind of the backdrop of where people are living, learning, working, and growing. They're just what's there in the community. And that those realities in our environments give rise to the health conditions, and we address the impacts. But I think that perspective in healthcare is changing as the body of research around social drivers of health is growing. And the people in our communities, especially as Indigenous people, view this differently. Health doesn't necessarily happen in an exam room for us. So as we continue to grow that understanding and push back, I think healthcare and Western science is also beginning to expand that view. And the impact of those drivers of health on our people has been disproportionate. As American Indian and Alaska Native people, we have experienced significant healthcare disparities, and from this slide you can see some examples of that. American Indian and Alaska Native people generally have poorer health status than white people in the United States. We experience more physical limitations, we have more asthma, higher rates of obesity, diabetes that we're here today. The measure for that is that individuals have been told by a doctor that they have diabetes. And in general, our life expectancy is 11 years less than the rest of the population of the United States. And so our experience of those determinants of health, those things that are driving health, is a little bit different, perhaps, than others in the country. And part of the reason why is because of our history. It's something that's been rooted far in our past in most of our tribes and communities and our people. And so it's really important to understand for American Indian and Alaska Native people that those differences in social drivers of health have actually shaped our health, and that history and policy for American Indians and Alaska Natives have shaped the social drivers of health that are available to us or that are in our communities as well. It's not just that our people haven't made a decision to eat healthy or to exercise enough or to pursue higher education. It's really important to understand that in the context of our villages and communities and reservations or colonies or neighborhoods, if you're in an urban area, that relocation, separation, other policies towards American Indian and Alaska Natives in our history have really shaped what we experience. Indigenous people experienced societal level radical disruptions in their social cultures, in their cultural practices, in food systems and families and community relationships, in their ability to provide for their families and their communities and to self-govern as a result of the policies that were experienced. So it's important to understand that when we're talking about health and health disparities, that the outcomes experienced by Indigenous people in the United States and in other countries as well have their roots in more than just health behaviors and choices. They're rooted in some past policies that affect us and still affect us today. But that's not how it always was for Indigenous people. As we've learned from our elders and the histories that were passed down to us, our communities were once healthy, they were thriving, they had healthy lifestyles that rose from cultural ways of knowing that built strong bodies and strong minds and strong spirits, and they were centered on family and community, and respected the fact that we are all interdependent as people, and that we're part of a larger world that fits in with other creatures, other animals, the land and the water. And so as I began learning about social drivers of health and thought about health outcomes in Indian country, you heard I've been working for nearly 30 years in our population, and there's a lot of differences in our health, as you see, and trying to understand why that is when I know that I come from strong family, strong people, strong community. How does that all interrelate? And so to understand it, I needed to kind of work out that relationship, and ended up developing this visual metaphor to help me make sense of it, because I'm a little bit of a visual person and I need to understand relationships, which, by the way, is part of how we understand how to be as Indigenous people. So when I looked back and I looked at the bedrock of people, family, and community, and you see this tree up here, this living organism that's up there trying to live out in the world and absorb the air and water, but it has a root system that goes down through layers of soil and different things that are nourishing and helping that tree to live. And that tree represents us as Indigenous people, and as that organism that's out there trying to live in the world and be healthy and nurture, but is impacted by some of the things that are around us. And when you see that those roots reach down all the way to the bedrock, that bedrock of family and community and ways of being, it's something that I still, to this day, struggle to articulate when I explain what that means. It's something that's inside, and it's something that you can feel. It's something that you just know, but it's really, really difficult to articulate and to translate. But when I speak to my children and I tell them things like, this is who you are, they understand it. They're all grown adults. It will cause them to do things that they wouldn't normally do because they're introverts and don't like to engage in public places. But but because it's who they are, it's connected to who they should be as Haida and Tlingit people, they will engage in those things. And so as I was learning about this, and understanding we're rising from that solid place, what happened? What changed? Like, the things that we see as challenges and struggles in our communities today don't align with that. And so when I learned about this layer of parent material, what I learned about that is it comes from other places. It doesn't rise from the bedrock, but it comes from different places, which may be miles, it may be feet, but it comes into that environment. And so when we think about the things that I mentioned, you know, the policies that have affected American Indian, Alaska Native people in our history, that was something that changed conditions. It came in and changed conditions for us. And I don't want to dwell on those things, but if you haven't done some reading about it, if you haven't looked at some of the historical documents, it's worth your time to take a look and understand so that we can move forward from that past. But those events and traumas from policy then led to results for us. They disrupted family, they disrupted community, they interrupted the way that we knew how to be in the world, the things that we eat, the cultural practices that we have. I mean, these were vast societal level changes that were happening in our communities. And as a result, it led to some really not surprising negative outcomes, right? I mean, I can imagine that kind of disruption would not lead to health. It leads to other challenges and ultimately to our health disparities. But we see that disruption and injection of really difficult things into our communities have led to things that we still see in some of our communities. We still see challenges with interpersonal violence. We see challenges with substance use and domestic violence and other things that are continuing to impact our health. And meanwhile, all of those things are affecting the health of our tree and ultimately resulting in the things that you all are here trying to change, right? You're all here trying to change the trajectory of diabetes for Alaska Native people. And so the result of this disruption in history is things like depression and anxiety and diabetes and heart disease and cancer and obesity. And meanwhile, this tree is out here trying to live over here in this environment where we live, learn, work, and play. And it's not all of the things that affect our health. So as we look at this, I would challenge you to consider the things that are underneath the surface that are also impacting our health as we get to this. Because if we really want to change health, we're going to need to start to get to these things that are in the roots. I want to say one last thing about this other arrow that's over on the side. So while these things are directly affecting our communities, they also affect the things that are available in our communities. So that history of things that are present in our communities. I want to go back, to this slide. So where we live is in very rural locations, often outside of the food system. We have dusty roads that aren't paved, that contribute to pollution in the air. We have limited access to things like broadband in a lot of our communities. And those aren't things that happen by chance. If you look at some of the historical documents, there was intent to separate from the rest of society. It affects things like our food and nutrition. When we were removed, the ability to access traditional ways of gathering or growing or hunting were disrupted. As you know, the whole boarding school era that's been well in the news and very recent, just a few days ago, we commemorated the day of September 30th that we remember those children. That pulled people out of family and culture and community. I can't even imagine being a 4-year-old child put in a completely different place with a language that I can't explain how scared I am, or that I'm hungry, or that I'm cold. So our education systems was disrupted, and that affected ability to grow into healthy young adults who then understood how to parent even. So these disruptions are not by chance, and the real take-home point is it's not just about a choice to eat healthy or a choice to run or to exercise. Those things go deeper, and we need to deal with the things that are underneath and get back to our understanding of the bedrock. That bedrock, it says the people. When you ask indigenous people who they are, they give you a name, like Kis Hatai, that's me, or Denina, or if you're Navajo, Dene. And interestingly, all of those words mean the people. Havasupai means the blue-green water, the people of the blue-green water. Anishinaabe is the original people. Those are the things that we use to describe. So when I tell my kids this is who you are, this is what I mean. That's what it means to be a Kagani Haida, is all of those things that make us strong and healthy. Now, I'm going to shift gears a little bit after I go back through all these animations. So what's the relationship? So we know these things. We know that they're present in our communities, and they have ongoing impacts, right? Whether or not you have healthy food, if you have diabetes today, and can eat well to keep your blood sugars in good control, that's all dependent on access in your community. But there are longer range impacts that play a role in social drivers of health as well. And our stress response is actually a key part of that. And so I'm going to talk a little bit about this. And I know we have kind of a broad range of folks in the room, so I'm going to try not to get too deep into the physiology of it, but enough for us to understand the relationship. So in our stress response, you have two pathways that your body responds to stress. You have the sympathetic adrenal medullary axis, and that's the system that is initially accessed and releases adrenaline and noradrenaline when we experience a threat. So the fight, flight, or freeze response, you see a car barreling at you, and all of a sudden this system kicks into gear, and you start to release your adrenal medulla starts to release hormones that cause changes in your body. Your eyes dilate, you start breathing faster, blood shunts away from your stomach and brain and goes to those muscles so that you can get up and run. Your blood pressure increases, your heart rate increases, your liver starts to convert glycogen to glucose, so you have immediate energy so that you can feed those muscles. So your body is ready to take off and run. And then shortly behind that is the triggering of the HPA axis, or the hypothalamic pituitary axis. And that also causes a neuroendocrine cascade that then causes the adrenal cortex to release cortisol. And you're probably hearing a lot about cortisol out in the world today. I find it invades even my Instagram feed these days, that there's not a day that goes by that there isn't some solution to address cortisol in our bodies. But both of these systems, are responsible for helping your body react to stress. And both of them have a negative feedback loop. You see this little red circle with the line in it. So once that threat resolves and your body realizes the level of those hormones in your system, it should resolve and quiet down and resume its normal state. But in conditions where we have toxic stress, and this is overwhelming, unresolved stress, things change, and the HPA axis that I mentioned gets dysregulated. So, and this is stress that is intolerable stress. It's not the positive stress of overcoming a challenge, not like studying for a big exam and being stressed about that exam until you pass that test and you get that good grade on it. It's overwhelming and unrelenting stress that doesn't remit. And so in the face of that situation, that negative feedback loop that I mentioned becomes dysfunctional. So all that stress and that cortisol is being released into the body. The hippocampus and the amygdala see a stressor, and they release all of the hormones into the system, and that triggers a series of additional impacts onto your body. So I think it's probably really hard to see on this slide, but it leads to exacerbation of chronic conditions. It affects things like high blood pressure and obesity and cardiovascular disease, because that sustained glucocorticoid production really has detrimental effects on your body. It's designed to be shut off when the threat is over. But when that threat doesn't get shut off properly because this dysregulation of the feedback loop occurs, or because there's chronic stress in your life because of the conditions that you're living in and facing on a daily basis, don't allow it to remit. It leads to things like insulin resistance and wear and tear on your organs that ultimately result in health conditions later on. It impacts the endothelial cells in the cardiovascular system, and ultimately can lead to the chronic diseases and the health disparities that we mentioned earlier. One other note I want to make about this is that additionally, individuals that have grown up in environments where they've experienced a lot of adverse conditions, and those of you that were here last year, I'm sure heard Dr. Ann Bullock speak, and she always speaks about the impact of adverse childhood events on our bodies and their relationship to chronic disease and diabetes. When that kind of environment is also present, not only do you have this stress response that doesn't turn off well, but then you get a hyperactive stress response. You basically end up with a hair trigger. So that something that might be seen as a threat or not a threat to you, you might perceive as a threat. You see something out of your corner of your eye and you immediately assume it's the car barreling at you, when it's just a car turning right and going the other way down the street. So your perception of threats is also hypersensitive and triggers this response a lot. This slide is a great summary slide. There's a lot going on in the slide. These slides are available to you for download, so feel free to take this and take a look at it. But I include it in here because it shows the relationship that we've just talked about. So the social drivers of health that are available in the community and impacting health may contribute to chronic psychosocial and environmental stressors. So if there's limited housing, if you don't have a job, that can help put food on the table for your family. If your education system is not good and your child is getting bullied, I mean, there's so many potentials in our communities that can contribute to that stress. It causes this cascade of events related to chronic inflammation in our body and triggering of those stress axes, and ultimately bringing you down all the way to this development of the chronic diseases that we've been talking about. But I want to also point out over here on the left is there's also an impact with epigenetic modification that can occur as a result of this. And if you heard Dr. Bullock speak, I'm sure she spoke a bit about epigenetics. Epigenetics is the study of how our genes are activated and turn off and on, and the things that cause that. So how do the conditions in our environment affect how do the social determinants of health or social drivers of health in our environment affect epigenetics? Well, we understand that the genes are coded with markers that turn those genes off and on, and that changes in a toxic, stressful environment can actually cause changes to that epigenome, and that affect the development of cells and organs as well during that time, and programming impacts into things like the brain and the heart and the kidneys and physical and mental health that can be lifelong. And these leave biological memories on our genes in the epigenome. And it's especially important to understand that this is really impactful in sensitive periods of development. So in early life experiences, this is that connection to adverse childhood events. In the prenatal period, in the first 2 years of life, there are these sensitive periods that are impacted by that environment and leave those epigenetic markers on the gene and how it's expressed. And so 20, 30, 40 years later, that risk of diabetes or obesity was encoded, and then the environment that we're living in and working and growing and playing in can then impact and turn on the risk factors and genes like that. When I first learned about epigenetics, listening to Dr. Bullock for the first time, it was one of those pivotal moments in life that you realize your world view is shifting. And it was like an 1.5 hour long talk, and at about 50 to 60 minutes in, I was full. I couldn't process it anymore because I've worked in healthcare for how many years, trying to help people live healthier, longer lives. And then I learned that this happened long before they even walked into that exam room, right? And things that are affecting it that I don't have any impact on. At least that's what I thought. And I had to process that for a few months before I was ready to recognize, well, if I can't help provide a health care system that supports them when they walk in the room, when they're ready to deal with a health issue or be on a path to a healthier life, I'm not supporting them well. So no, Jana, you didn't waste 20 years of your career being a nurse in healthcare, not having enough of an impact. But what it also told me is that if we can turn genes on, we can also turn them off. And if 50 to 80% of the health outcomes are modifiable because of the conditions that are in the environment that we live, learn, work, love, and play in, we can change the conditions that then change how the genes are encoded. Part of the ways that we do that, while we have negative influences in our life, you can do this even with young children, right? If they live in learning-rich, healthy environments where they're nurtured and they have access to good food, you already are changing the chemistry that encodes their genes and causes modifications in how those are expressed. So a lot of work has been happening in Alaska in the last decade or so around children and early life. And I know that South Central Foundation is working with Child Protective Services. These things are not separate from what you're doing in the exam room. They are all connected. I include in here a couple of slides that I'm not going to spend a lot of time on, but if you want to go back and look at them, there are additional slides that show the connection and the relationship and how those sensitive periods have lifelong impact in health outcomes. There's 2 here from the British Medical Journal that I think summarize it really well. This one has quite a bit of information on it, but you can see that it ties in the impact of the HPA axis and the stress response in the body, and ultimately how it affects development of nerves and neurotransmitters in the brain. Aji Wadlawan Ukud Kiwag. Everything is connected. Everything is connected. So if we've learned about all of those things, about what's available in our community and how it impacts stress and how that impacts not only genetic and early life makeup that affects us later on in life, and the conditions that are present in our community as adults trying to remain healthy, to stay healthy, it's all connected. And what do we do with that? I think as Native people, this relationship in the environment around us and our families and communities is one that's not a surprise to us. But in healthcare, we're just starting to get this, right? We are talking now about social drivers of health, and this is information that's been out there for decades. I sometimes share with people that I have a little printed socio-ecologic model that I cut out and tacked to my office wall 20 years ago. And it was my first real kind of coalescing of that kind of relationship and science. And it's been 20 years. But our people have known this forever. They understand that we're connected. And they understood that those early childhood experiences had impacts on our health, that it isn't just health choices and what we eat. So while our understanding has grown, that critical relationship between health and the environment around us and how we interact with it and with each other, and our health and physical and social and spiritual conditions within our community, they're all connected. And as American Indian Alaska Native people, being healthy means that they all also need to be connected. This quote comes from some work that is now a decade old. It was 2015 that this occurred, and 8 scholars from tribal communities and some mainstream educational institutes came together and convened to examine what the World Health Organization's framework for health in indigenous communities was missing. You know, what's not there that needs to be present for American Indian, Alaska Native, or indigenous communities to be healthy. And you can see in this, they understood that things, not just access to healthcare, not just access to education, not just the neighborhood and as-built environment, but things like security of access to food, to water, stress, the ability to access employment, all have impacts on health outcomes for communities worldwide. Social exclusion or inclusion impact those communities. And this question of what does health equity then mean in tribal communities, right? So if we understand that it's more than just those drivers of health that we saw on the screen, what is it? And if you look at this definition of health equity that came from some CMS work with American Indian, Alaska Native communities, you can see on the slide that it's more than just those things. You can see words in there like joy and safety, dignity, kindness, justice, sovereignty, generosity. Taking care of others is essential for our health. In fact, I heard it this morning, even as Seth was giving the land acknowledgement. He talked about us being caretakers of our land and our community. So these things that the National Indian Health Board and Centers for Medicaid and Medicare worked on to define this include far more than just the interaction with the healthcare system, right? They include far more than the things that we can control in an exam room. And inherent in this statement is that health equity for Indigenous people won't be achieved by simply eliminating deficits that cause health disparity, but also in recognizing that calling on strengths and assets are part of who we are as Indigenous people, and that they are needed to actively build health. So in an asset-based strengths view of the world, which most of our Indigenous communities look at, we need a model of health that looks at that differently. And what you see here is the Indian Health Service Indigenous Social Drivers of Health framework. And this is work that we've developed through the initiative that I lead, and that came from review of literature for Indigenous understandings of health and wellness. And if you note the differences in this model versus the Healthy People 2030 model, those 5 domains are still in here, but there's some key changes. Number one, in the middle, you see the individual, but the individual is encompassed by family and community. And we don't, as Native people, think of ourselves in an individual mindset. We're a collective people. We think about who we belong to as family members and community members. And as I got up here and introduced myself, that was exemplified in the way that we are taught to introduce ourselves. You heard who my family was and where I was from before you even heard my name, because that's who I belong to, and I can't exist in health without understanding that relationship. Also in here are the domains of, keep hitting that one, early life experience that we've talked about a bit. Food access, that's often hidden in social drivers of health models in the neighborhood and as-built environment. But for Indigenous people, gathering from the land or growing their food is about more than just access to food. It's about the relationship with the land. It's about the relationship with the plants, to place. Connection to place is part of who you are and how you know how to be in the world. Neighborhood and built environment, access to healthcare, economic stability, education, access and quality, those are all similar to Healthy People 2030. But in the social and community cohesion, for us, it's more than just, are you connected in your neighborhood? Do you have a social network? Do you have friends? Are you not isolated? It's, are you connected and do you belong? Physically, spiritually, are you part of that community? Are you part of that family? Are you integrated into their culture that you live in? So I'm going to pivot a little bit here, and these slides I'm going to actually go through fairly quickly. I know we're coming to time, but thinking about social drivers of health. So if it's this big thing, and it's far bigger than just interacting in an exam room, what do we do about that? Sometimes it feels a little overwhelming when you think about it. Like, we're healthcare people, now you're asking me to work on housing in my community or to change food systems? The short answer to that is yes, because I think that's what it's going to take for us to start to change health outcomes. But there are a lot of efforts and activities nationally in healthcare that are beginning to change this. So at a national level, even just recently, the Make America Healthy Again Commission released its report. They've released first a preliminary report in May, and then their follow-up report with 128 recommendations in it in September. And in that report, you see a focus on some of the things that we've talked about being relevant today: child health, chronic disease prevention, and policy recommendations to help with that. It calls for actions to address nutrition and physical activity in children and to combat chronic disease, all good things. And also to restore science around the things that make us healthy, or I would say contribute to the body of science rather than restore. But this work builds on work that was already in place. The HHS work group that was mentioned has been present for a number of years. In 2022, we released an action plan with also recommendations and activities to promote health in our communities through improving access to health care and aligning across government programs and supports and partnerships to support social drivers of health in our communities and enhancing data infrastructure. I've included some federal resources in here if you want to read more. You can see that this was a collaborative relationship with many agencies. So CDC, NIH, Indian Health Service, HHS, CMS, all involved in this. And so activities are happening at a national level to help support the changes that need to happen in our communities as well. Things like the Medicaid 1115 waivers. These are demonstration project waivers that are happening in some states that are paying for things that support health through addressing health-related social needs. So case management for people who are struggling with housing, even payment sometimes for secure housing for people who are experiencing health-related social needs as that are impacted by a lack of housing. Food is medicine programs, produce prescription pilot programs, those all fit into this area. And then there were also regulatory requirements, and most of you probably aren't from hospital settings, but just in case, has anybody been working on required screening for social drivers of health or health-related social needs over the last couple of years? I suspected not. But because of that full government approach, they were also driving change through regulatory requirements and requiring that people be screened when they come into the hospital to determine if they have a health-related social needs. This was recently removed in the inpatient prospective payment system final rule, the outpatient prospective payment system final rule, and the rural hospital quality rules, all of which are in some stage of either having just recently been released or will be released. But I want to point out that while that removes a regulatory requirement to report, it doesn't remove the need to understand the health-related social needs data of our people. If it's impacting health and health outcomes, we need to begin to change that. And it doesn't also mean that the government is no longer interested in it. There are some changes that also support that understanding and knowledge to continue. And here, the Medicare annual wellness visit, you can bill for screening for social drivers of health or health-related social needs on top of our all-inclusive rate. I think it's another $28. The physician fee schedule in 2024 introduced this screening and actually, for the first time, actually specifically designated that screening done by community health workers could be reimbursed. So that's the first time that CMS actually was starting to reimburse for work done out in the community by community health workers. They expanded the providers that can screen. They introduced principal illness navigation. So not only do you screen, but then you can case manage and work with individuals out at home and in the community to address the health-related social needs, and CMS will pay for them. And then in the 2025 fee schedule, so even though they've removed those things, there are some things that are interesting that you should be aware of and pay some attention to. I think Dr. Cummings is going to talk a little bit about policy. Policy is not everybody's ball of wax, but sometimes it's helpful to pay attention. Just recently, the request for information for this proposed rule closed. It actually closed on September 25th, but some of the things that they were asking were, can other people work on health out in the community? Can we pay for community programs like fall prevention programs, for exercise activity that's occurring outside if we track it with digital monitors? How many of you would be interested in being able to bill if your patient has a Fitbit and they're out doing some exercise at home? There are some things that are relevant and need to pay attention, and they all give us data that help us start to understand the conditions that we need to change in our communities to support health. That data comes from the healthcare system, but it also comes from the community, and it comes from the indigenous knowledge that's in those communities. And I am running out of time, so I am picking up pace fast. There's also work that's been occurring at the Indian Health Service. So you all are now compacted or contracted tribes, but at a national level, our agency is also working on this. And we, in 2023 and 2024, did health-related social needs screening sprints and included both federal and tribal facilities to begin screening for those health-related social needs. And building the data infrastructure and information system infrastructure so that we can start to know where the needs and hotspots are. And you can see as of June, almost 41,000 individuals in the system had been screened for health-related social needs. There's developed a toolkit. We've worked on electronic health record. And then you need to understand, once you start to get that data, what do you do with that data? How do you transfer that data out into community and start to make changes in the community? We launched a pilot called the Reshaping the Drivers SDOH Community Engagement Collaborative in fall of 2024. And this collaborative is built on a theory of change that you see in front of you. And I'm not going to go into depth with this because of time, but I want to point out a couple of things that are in this driver diagram. Any of you familiar with driver diagrams? I love a good driver diagram, and nobody is raising their hand. Driver diagrams tend to be very linear, but in our indigenous ways of knowing, we're not very linear. In fact, we're very cyclical. And so this driver diagram is unusual, but you wouldn't know that if you aren't a lover of driver diagrams. So, but I want to point out up in the upper right-hand corner, and especially, is that right? Your right and lower right-hand corner. Engagement in community is a cornerstone for this. You have to be in community. You have to be talking. You have to be working. You have to be collaborating. You need to be together to identify the needs and priorities in the community. And then in this listen, learn, and understand, understanding that Indigenous knowledge is an equivalent knowledge system, is a cornerstone of this as well. That might be my timer. So this theory of change is a cornerstone to how do you start to change the drivers of health. This is the model that it's built on. Come talk to me if you want to learn more about it. But everything depends on everything else. It's inherent in our understanding of the world and the way that we live in it as Indigenous people. So to improve our health and support and wellness, we have to have a response that addresses those drivers of health fully. And our tribes get this. You all get this. Just quickly, this is my tribe. This is work that's being done. I spent a couple of hours now, about 2 years ago, just looking to see what they were doing to support health. And look at these programs. In healthcare, we're often trying to create these programs. We're trying to make them. We're trying to put a food pantry in the closet in the ER because we know we have a food system issue and people are not getting adequate food. My encouragement to you is to connect. This is Siri. I did the same thing before coming here and just thought, well, what's going on in Anchorage? And you can see they get this. They're addressing each of the drivers with programs. Tanana Chiefs, I just went to some of the big ones. Look at the programs: food resources, food sovereignty, early childhood learning. This is not a surprise to our people. So my challenge to you is to connect in your communities, connect to your tribe, connect to the programs, because addressing health will require that we work on those bigger drivers of health and move upstream. And I'm ending here with this last little bit of connection. This is one of my grandchildren, and this is Addie. She lived in Rhode Island. They now live in Hawaii, but she came to Alaska. And one of the first things that we had to do when she came is take her out in the bushes so that she could pick berries. Because the memories of my mom and my grandma and how I learned how to be and to be healthy in the world, lots of them were in the bushes. I can't pick berries without thinking of them. And so Addie got to continue that, to connect, to move to the next generation and be healthy. And the audio is not connected, and I was afraid of that. But what you see in that picture is me saying to her, "Dangdi koyadang," which means I love you, because she needed to hear our words. And the last picture that you'll see that you also won't hear is over a year later. Oh, you can hear that one.
Good job.
Hunt is water. So over a year of FaceTime and visiting and me speaking a language so she can hear it, so she can understand who she is, even if she is not in Alaska, means that this little one understands that she's connected. Thank you, and I will turn it back over.